Hi, everyone. My name is Zehra. I'm a third-year medical student, and myself and my co-authors, Karan and Victor, did this poster about our research on barriers of care to ovarian cancer. So just to kind of introduce this, ovarian cancer remains a very serious issue in the United States. And in fact, it's a leading cause of female cancer-related deaths, which makes it the most lethal female genital tract cancer. So as you can see, it's a very serious issue. Unfortunately, a vast majority of patients are still diagnosed at advanced stages, which results in worse prognosis for patients, of course. And what we found is that if you were to diagnose at stage 1 ovarian cancer, there's a 90% cure rate, which is, of course, amazing. But unfortunately, less than 20% of actual ovarian cancer cases are being diagnosed at stage 1. And so that means that patients are then being subject to disease progression. And of course, there's greater risk for possible death, which we want to avoid. So we also have research that shows that early stage detection of this cancer can in fact improve survival rates by as much as 30%. So if you're paying attention to these numbers, early detection is very important here. And of course, early detection and access to care are very closely related, but there's a lot of barriers to receiving care. And so many patients aren't receiving guideline adherent care, and that's leading to later diagnoses. Race, minority status, socioeconomic status, these are always linked to worse outcomes in a lot of aspects of healthcare and indeed in other aspects of the country. But it's the same with ovarian cancer outcomes. Even independent of race and SES, though, there's patients that are being diagnosed at advanced stages. And some reasons for that are what we're going to go into today. But the scoping review essentially was to explore the available evidence that we have on ovarian cancer and to kind of identify these barriers so that we can have more effective treatment options for patients. So just very quickly, let me go over methods. We just used five databases, and we did this based on inclusion-exclusion criteria. So essentially, we were looking between 2002 and 2021, and we were trying to focus on making sure that there were articles discussing barriers such as SES, racial, demographic factors, and we did use articles that were full text in English. So our figure here is a Prisma flowchart. It's basically just detailing our process in choosing the articles that we used for our scoping review. And so our initial search gave us about 58 articles, and then through manual review, through putting it through a search engine and whatnot, our final studies ended up being 10. So the results that we found was that, first of all, less than half of women diagnosed with ovarian cancer received the recommended care. And that was due to low SES, low volume surgeons in hospitals, race, type of insurance, lack of insurance, non-English fluency. So there's a couple factors here. We have something called low volume hospitals, LVH, and low volume physicians, LVP, which we're defining here as hospitals and physicians who see a small number of ovarian cancer patients. And these LVPs and LVHs are linked to lower ovarian cancer survival. And what was found was that Black patients were more likely to receive care at these facilities, as well as patients with Medicare and low SES. And factors that resulted in high volume physician care included being white and having private insurance. So another aspect here was, no worries. Observed expected ratios at hospitals. Hospitals with high ratios essentially had higher disease-specific survival times with about 79.3 months as compared to hospitals with low expected observed ratios. And they had survival times around 44 to 50 months. So even after controlling for a bunch of other variables, it was found that hospitals with these higher observed expected ratios were associated with higher survival rates. And patients that were in the highest SES, socioeconomic status quintile, were 2.5 times more likely to be seen in a hospital with these higher observed ratios than those in the lowest SES. So another factor was geographic location. Guideline adherent care was independently associated with patient proximity to a high volume hospital. So that HVH that we were talking about earlier, that's associated already with higher survival outcomes. And so what was found was that white patients and those with higher SES were also associated with highest access and proximity to these HVHs. So moving into a different direction a little bit, high-risk patients reported that they were well informed about risk-reducing procedures such as the risk-reducing bilateral salpingo oophorectomy. But what they did say was that they felt that they were either misinformed or didn't have enough information about post-op complications. And additionally, about half of high-risk women said that they weren't provided with written resources about this procedure. Additionally, there was issues with figuring out who to give referrals to, where to give referrals to, and at what stage in the timeline those referrals were to be given. And medical professionals also were requesting additional information about post-op complications, about the standardization of, when to refer and things like that. So there was kind of lack of education in terms of both physician and patient. So I want to move on to discussion a little bit here. We did identify several barriers to care. And that was low socioeconomic status, the LVH, low volume physician that we talked about just now, race, level of patient education, geographical distance, patient education on treatment options, physician education on treatment options, and lack of information on risk-reducing procedures. One main barrier that we did identify in multiple studies was the availability of appropriate ovarian cancer providers. Access to these individuals can be very limited, and it was even more pronounced for patients of racial minorities and low socioeconomic status. So as you can see, this is another survival disadvantage. Also, geographical distance from HVHs was associated with low SES and racial minorities. And that geographical distance from these facilities is in turn linked with increased non-adherent care. So again, this is another survival disadvantage for those groups. In terms of patient education, a lot of patients were they said that although they were educated about the option, they didn't feel educated or properly educated about post-op complications. And that in turn caused them to not agree to that procedure. And of course, as we've discussed, this is a life-saving treatment for a lot of patients. And so it's reducing kind of a treatment option in a way because patients aren't being properly educated. Also, a lot of physicians felt uncomfortable or felt lacking in their knowledge to be able to properly speak with patients about this. Additionally, we know that a lot of physicians rely on a high index of suspicion to proceed with ovarian cancer care, which in itself is not a bad thing, but it becomes a little bit of a treatment barrier when it comes to patients that may be perceived as low risk because they're not receiving screening until much later. And so that's resulting in late stage diagnoses, which we talked about earlier. Additionally, there's many patients that are simply unaware of genetic testing. And what we saw was that minority patients, and specifically Black patients, were the least likely to be aware of genetic testing, which can be used to check for high-risk patients. So in conclusion, our scoping review sought to find some insight into barriers to ovarian cancer care. And we did find that members of disadvantaged socioeconomic groups and minority groups may be left without the medical attention they're deserving and they're needing. A lot of our studies also found that adherent-based care is challenging to follow, and it's worse in patients of lower socioeconomic status and racial minorities. And so what this is showing is a clear need for physicians and healthcare providers to be better educated in post-cancer treatment, follow-up, and patient education. And what we're hoping is that in the future, findings of this review will be able to provide health experts and in fact patients with better insight and better ability to advocate for themselves and for others about what barriers exist and how those barriers can be kind of curtailed for most effective and best ovarian cancer management.